Professor Santucci, thank you very much for accepting our invitation to do the interview. Could you do a brief introduction of yourself to our readers?
Sure. I'm a urologist. I'm a fellowship-trained expert in trauma and reconstructive urology. So what that means is my clinical interest is in reconstructing the urinary tract, often using plastic surgery type techniques that we borrowed from plastic surgery. But somehow, because of some strange historical thing that happened decades ago, a lot of us are also interested in trauma surgery as well. So I take care of a lot of patients that have had injuries to the genitourinary tract, either through violence or accident, or sometimes iatrogenic injuries, like, say, ureteral injuries during a general surgery or gynecological surgery.
Okay. As an expert in reconstructive urology, what's the most challenging issue do you think in this field?
That's a great question because it sometimes seems like it's all pretty challenging. One of the problems with having to functionally reconstruct any part of the body is that we're not terrifically good at it. If you lose an eye, you pretty much lost the eye. If you get your leg cut off, you pretty much lost that leg. And so I think we could do a lot better. I think these will be considered the dark ages of reconstructive urology in the future. What we really need is off-the-shelf materials which can be used to reconstruct a urethra, reconstruct a bladder, and reconstruct a ureter. Right now we're using natural tissues from the body, and a lot of times there's a lot of donor site morbidity or limitations in how much of that tissue you have. So I think the biggest problem with our field is that we're awaiting a breakthrough. And the breakthrough is to have reconstructive materials that we can just pull off the shelf and use as much as we need to that work.
Yes. So over the past several years, how many progresses in this field do you witness?
Well, in speaking about reconstruction, a lot of our real wins have been small wins. And yeah, so we haven't cured cancer or made malaria go away or any of those things you really look for. What we've learned, though, is to try and be more scientific about our field and to use a combination of multi-center trials and specific trials designed to answer big questions in the field to get what I would say a little bit better. So, for example, we now know that if you have difficult urethral stricture, perhaps a long stricture or penile urethral stricture, that probably the answer is to use a buccal mucosal graft using a series of steps really described by Dr. Kulkarni in India, which we now would call the Kulkarni technique. Now that still has a 20% failure rate. It's still a 3 to 5 hour operation. It still requires multiple incisions because you have to take mouth graft tissue from the cheek, the tongue, often the other cheek, sometimes the other side of the tongue. But we have done a reasonably good job of codifying what works and what doesn't work in reconstructive urology. In trauma, we've done a pretty good job of realizing that there was a moment about 20 years ago where we were masters at operating on the kidney. We had learned how to do partial nephrectomies and really difficult nephrectomies for cancer. So we thought, well, the answer is for trauma that these people need operations. And I think what we learned about 10 or 15 years ago is that, wow, maybe they don't need operations for most cases. And if you do operations, you might actually be putting that kidney at risk. So I think that's a major change and improvement in the way that we do trauma. So those are probably the biggies.
So could you share some insights about the future development of this reconstructive urology?
I think in the reconstructive world, the big breakthroughs will come in what I've already described as being important of off-the-shelf reconstruction materials. I think robotics is becoming increasingly important. We are now doing robotic operations that we wouldn't really have done robotically before, would have done them open as a matter of course. So that would be a UPJ obstruction or a distal ureteral repair. Most of those people are going to do robotically. Now we're pushing that into doing robotic buccal mucosal repairs of the ureter, and even some people are doing robotic ileal ureters, which is highly technical operation. And I think there's no question that if you can do a vesicovaginal fistula or urethral rectal fistula robotically, that the patient's probably better off for it. So I think that's what's happening to us in the sort of short-term future.
Well, thank you. So final question, what do you love about surgery?
Well, I do love surgery. I love urology, and I think I became a urologist because our surgeries work. We have a raft of highly successful cancer surgeries. If you have a patient that can't void because of obstruction, almost always you can fix them. And there's not a day that goes by when I'm not fixing someone's urethral stricture that I am not pleased by the cost-benefit ratio to the patient. That they have some surgery, sure, they've got to get better from that, but their quality of life improves. So I really love surgery, urology, and reconstructive urology because it works.